thankful for all your attention and open it up to questions now.
You're saying that the calcium test is very important.
It's important for most people. The one caveat is if you've already had a heart attack, you have a stent, you've had bypass, you're already high risk. This study won't give you more information.
But if you don't have any problems, you don't think
If
you
you,
do.
correct, if you don't
That would
know,
be the test to have.
if you did nothing else from a testing point, that'd be the one test I'd recommend. It's about $100.
What do you think about Lifeline?
It's good question. Part of Lifeline is decent. Lifeline is one of those services that usually come to community service or gym or church, and they offer a set of different vascular imaging. So the parts of it I think are good are the when they're looking to see if you have an aneurysm in your abdomen, and they're checking to see, right, and they'll do a carotid scan that looks for severe plaque, but they're not measuring the thickness of the artery. They're not giving you a vascular age. So it's a pretty good marker if you have severe disease, but it's still not sufficient enough to tell you your true risk. Yes, sir.
I have a question about the sleep.
Mhm.
Is it necessarily, I guess the best way to try to describe it would be myself. I fall asleep before my head has been my whole life, no problem. I do have severe sleep apnea. I've been on CPAP probably 6 years. Even before I was on CPAP, I had no concept of being worn out. I never felt worn out. The only thing that's really remarkable was that after I had been on a CPAP machine, Bridget got me a Fitbit, and some of the things I figured out was like resting heart rate. My resting heart rate reduced probably by 20, 25 points over about a 1.5 year period.
Mhm.
I mean, now I'm probably somewhere in the mid-40s to low 50s, probably depending on now I've heard some good stuff on when I eat and things like that.
Right.
I don't sleep probably more than maybe 5 or 6 hours a night. I wake up rested. I don't have any problems feeling sleepy during the day. So I guess, is it possible that a person can sleep well enough during that time that makes up some of the difference for not sleeping long enough, or is that not possible?
It is possible, but it is extremely rare that people will thrive on 5 hours of sleep. There's a few genetic abnormalities that can drive that, but anybody who's sleeping, there is no magic number of hours of sleep. It's the quality of sleep that's important. Most of the data shows that people, the quote healthiest people are probably sleeping 6.5 hours a night. That does not mean you should shoot for that. That just means that's all it takes is 6.5 hours for that person to run their kind of recharge program at night, and they're ready to go. Their battery's charged up essentially. If you're needing sleep 8, 9, 10 hours because you can't function, maybe you have an autoimmune condition, you have cancer, you need more sleep to repair yourself. So I can't answer it specifically without actually knowing your case more. I'd have to know your biomarkers and do you have vascular disease. If those people have vascular disease, they need to focus on the sleep so they can reverse that.
So you recommended fish a few times a week.
Mhm.
How do you feel about a vegan diet that has no fish meat?
What is the actual question about? Is it just, what will happen?
Is it better to not do vegan and include fish?
Well, it's a hard question because veganism is somewhat of an emotionally charged topic sometimes. But from a nutritional standpoint, your body needs DHA to fully function, and you're not going to get that through regular foodstuffs eating a hardcore vegan diet. So I'll work with my patients where they're at. But if they want to be optimal, they're going to have to somehow improve their DHA. And yes, there is quote algae-based DHA, but the data is that it's complicated. It's in the it's not in necessarily the right form that your cells will uptake it and use it.
I didn't do it because of animal rights. I did it because my cholesterol was high. And when I went vegan, my bad cholesterol dropped 20%. So I thought that was my doctor's like, oh, this is great, and keep it up. But I was wondering if I should be.
It always begs the question of what was the diet before you went vegan? Because
Paleo.
okay, so it depends on again, it's hard to know without seeing the exact numbers because there are certain people that have an abnormality in one gene that makes it hard for them to digest the certain fats, and if they do a paleo or keto type diet, their lipid panel goes abnormal. But again, it's more complicated than good cholesterol, bad cholesterol. Just because your quote cholesterol went down 20% really doesn't mean that your heart attack risk went down 20%. It's all about how much inflammation is there and what's been going on with your arteries for the time you've been on this earth. But, I would focus, like I said, more on, I'm not dodging the question, but it's like really focus on the mitochondria, what makes those things work? It's your light, it's your sleep, it's the water that you put in the systems. So if you're doing those things and you're feeling awesome, then go for it, eat vegan. But if you're really sick, it's sometimes hard to be very optimal on a vegan diet because you're not getting some of the nutrients your body truly needs. Yeah. Yes, ma'am.
So you were talking about the difference between the genetic factor and really it's more your lifestyle than it is genetic. So if our family had, mom had carotid, 90% or plus carotid artery issues. So one of the boys at 40-ish to 50 had to have a bypass in his leg because of that knee clot. And another one had quadruple bypass heart surgery. What are your thoughts on genetics? Still more lifestyle, they probably raised all the same?
No, but I mean, that's why I say it's not as easy as saying that genetics don't matter. But in that case, when somebody has early vascular disease in their 50s and a bunch of people do, I'm concerned they have lipoprotein A, number one, that rings a bell in my head. And then there's a couple other things I'm going to start checking. But, but again, it's still your environment is going to even trump what your genetics are the greatest majority of time.
This line of testing that you do, does it help you help a patient get on the right track when you get the results necessarily?
I mean, every patient's different, but
Yeah, right.
I'm a data-driven person. I want to show them this is how healthy your arteries are. If you don't change anything, this is where you're likely going to end up. If you do these things, you're likely cutting your risk in half. So, I never completely, prescribe something to somebody. I'm not going to say you must take this medication. It's, if you do these things, your risk is going down. So I want to work with them. What are their goals? If it's, I want to live to see my daughter's wedding. All right, I'm gonna throw the kitchen sink at you. If it's, I just want to be able to play sports and not be, sore. Well, then maybe we don't need to be, as aggressive with certain things. Then. So, but being data driven, I can actually show people if you do these interventions, look what happened. Here's your biomarkers; they're changing, or your carotid scan, it's improving. You're improving your vascular system.
So for somebody that's never had any, have been symptomatic as far as the heart or any of that, it might still be a good idea to go in and do some of this just to see where you stand, right?
Yes, I mean,
Yeah.
I'm slightly biased in what I do, but but I think almost anybody over the age of 40, should give it a consideration. Do some of the tests. You don't have to do the whole battery of tests, but if your risk is low, stay with your primary care doctor, whoever's helping manage your health. But if we throw you through it and you get a tripwire and you're high risk, you come in and see me. I mean, I saw a gentleman today, low risk score, but the highest score I ever saw was in a guy who was 48 years old. The calcium scan rarely is over 1,000. This guy's was 5,600. We did a heart catheterization on him. He had severe disease. We couldn't fix it with stents. It was so severe. He had to go to bypass surgery at age 48. He wouldn't have got picked up unless he had this calcium score or had an event at home. So, I sometimes call that one kind of a blind squirrel finding a nut type thing. But, but in my line of work is that I'd rather find that one guy once a year than miss that guy.
So that guy, what do you do for him post-bypass surgery?
It's a good question, but he had a little bit of extenuating circumstances why I think the calcium score got so high, but he would have got this exact same regimen. I mean, that's also, I can't necessarily stand up here and claim that I can prevent every single person's heart attack across the board, but it's extremely rare once people start working with me that they have events. Frequently I would inherit patients when I was still working in a lot of different hospitals. They were coming in with heart attacks. We did all the standard care stuff, and then you're still going to need that when you're having a heart attack. We fixed them up, and I said, hey, in 4 or 6 weeks when you're healed up, come see me in the office. We're going to do this blood work panel and try to figure out why this exactly happened to you. And more times than not, I can usually point to something that I can say, okay, if we work with these things, it's much less likely you're going to end up here again. Because that was the story when I was in training, is that being in the cath lab, it's kind of fun. I mean, it's exciting. You're fixing things. You think you're making a difference, and you are acutely. But if those persons don't do this stuff, we'd see the same guys back in 6 months, and they're doing patchwork somewhere else. I mean, you know, there are times where, you know, stenting somebody's going to save that person's life, but if it's a, you know, standard patient who's out of the community just having some symptoms and it's not a heart attack, that stent's not going to make that person live longer, and it's not going to make them not have a heart attack. It just kind of props open a blockage. You know, it never fixed why that blockage got there, so you've got to really address these root causes.
And so you'll work with patients who don't live in Missouri, who don't live in St. Louis?
Correct.
Just coincidentally, I came for my husband and some others, and probably myself too, but just recently my grandma is like in the hospital in California. She went in with elevated heart enzymes and heart rate, and, you know, they're doing all these tests, and she's almost 90, and, you know, nothing's really coming, and I feel like this could be something to really give answers and help her.
Right. So it's actually, you know, the technology is way advanced past what the regulations allow. So, you know, you know, have medical licenses in 3 states right now. So the way it actually would have to work is I have to either physically see the patient once a year in St. Louis or one of these other states, and then I can take care of them remotely. Or, you know, if they want me to be their kind of primary cardiologist. If they just want a second opinion, they're going to keep their cardiologist in whatever city they're at, and they just want to know a little bit more about this type of stuff, like, okay, how do I actually optimally eat, or what exercise should I be doing, or, you know, can you look through my supplements? I'm more than happy to do kind of a second opinion. I don't necessarily need a full-on license in that state if they're going to keep their primary doctor.
Or even like the type of tests that you do, like that they're not running there.
Yeah, I definitely can make recommendations for that.
Did I understand you to say that the cholesterol bad and good isn't as important, and that statins may not be doing as much help?
It's a good question. Break out in 2 parts. One, again, there is no such thing as good cholesterol. There's no such thing as bad cholesterol. That's a myth. Yeah, there's just cholesterol. And so, you know, if you look at a traditional panel, honestly, the only thing that's somewhat interesting on a traditional cholesterol panel of total cholesterol, LDL-C, HDL-C, and triglycerides, the only thing I really ever care about really is the HDL-C and the triglycerides, because it gives me an insight on how well you're burning sugar. The other stuff, unless they are sky high, which means you probably have a genetic abnormality that's causing the cholesterol to build up in the system, those don't predict risk. Those don't tell me who's going to have a heart attack. 50% of the people come into the ER with heart attacks have normal cholesterol. Doesn't mean much in that population. They had some type of cholesterol that was oxidized at some point in their life. They ruptured one of these little plaques, and that's what the heart attack was. Now, your question about the statins. You know, statins are a tool. You know, they're not a tool that should be used in every single person, so they should not be in the water, and they're not absolute, you know, poison for everybody. You know, but your lifestyle is always going to be way, way, way more important than a statin ever will be. Statins, the main benefit is probably that it's anti-inflammatory properties, that it's lowering inflammation so the arteries aren't getting damaged anymore, and that it's also likely making a cap thicker over any plaque. There's been trials, they were more invasive trials, where they had certain catheters, ultrasound probes up in the arteries, and they would take pictures initially, give the person a statin for a year, take the picture again, and they would see that plaque getting better. So that's one of the reasons why I will use the CIMT scan, because it's non-invasive, and in the right population, we'll still use a statin to help stabilize that plaque and reverse it. But, you know, if people have side effects with the statins, you know, I'm not going to say you must take it. You know, I will actually do a fairly comprehensive blood work panel to figure out what statin, if we're going to recommend one, which one you would likely tolerate. And then when people don't tolerate statins, it's for 3 or 4 big things usually. They're either vitamin D deficient. They almost always will have muscle aches and pains if they're vitamin D deficient. It's if their CoQ10 levels are low. CoQ10 is something that helps make energy flow faster in your mitochondria. The statins block that CoQ10, so that's one of the reasons why the muscles sometimes hurts, because the mitochondria and the muscles are being affected. The other thing is if your thyroid's underactive or hypothyroidism, very frequently people get muscle pains with statins. And there's a genetic test called ApoE. I don't need to go in that part, but certain people won't tolerate high-dose statins. So you pick the right medication for the indication. And, you know, I tend to use this calcium score test routinely because it even got added into the guidelines this year for the traditional cardiologists and lipid managing physicians that the calcium score test probably should be used almost as a tiebreaker. So unless somebody has a genetic abnormality where the statins is actually always going to be recommended, if you go do a calcium score test and your score is 0, there's very little evidence you should get any benefit for being on a statin. If your score is over 100 and it's less than 400, you should at least have a conversation with your doctor, risk versus benefit. What else is going on in this person? They're an uncontrolled diabetic, they've already had a stroke, but the calcium score is not that high. Well, that person's still high risk, probably would still lean towards the statin, but if they're otherwise healthy and they're going to go do all these lifestyle things, the statin is just a tool. It's not likely to be that beneficial in that person. Now, somebody's already had their chest opened up, they've had multiple stents, they keep going back for stents. Those are the people that you throw the kitchen sink at, so you're trying to prevent them from coming. Statins are a tool in that case that I would always recommend.
You mentioned sort of the traditional medical treatment, tests and things, and then I guess you might call it a little less than traditional, right? In some of the areas you work. How do insurance companies treat that? How acceptable are some of these things in terms of making a claim to have an insurance company pay for something, whether it be a test or a treatment course or what have you?
It's a very, very good question, and that's one I get routinely. Insurance companies aren't in business to do prevention for the most part, because prevention doesn't pay long term for them. Yes, it's very beneficial for you to invest in your health and not have a heart attack, but if you do something that's going to take 20 years before you don't have an event, that insurance company is probably out of business, or you probably already switched on to another insurance company. So they don't really have a financial interest in doing that. And if you actually think about what insurance actually is supposed to be, insurance should be more like your homeowner's insurance, like fire insurance. Your house burns down, unless you have the money in the bank to buy yourself a new house, you want the insurance to come in there and take care of it. That's what insurance ideally used to be for even health, is that you had a major catastrophic medical trauma, major surgery, cancer, you needed insurance unless you had a big chunk of change to pay for that medical care at that time. Now insurance is more like prepaid services. So they're going to have a limited menu of options that they're going to offer. If insurance was going to cover everything, insurance would be very expensive. So most of the tests, and I'm very transparent on pricing. The calcium score test, $100. The CIMT test, usually about $200. The EndoPat is $225, and then depending on which lab coverage you have for your insurance, most of the time the labs are usually covered in great part by your insurance.
Is there a sequence on those tests, or you recommend at least one or two?
It's a good question. Again, it's always going to break down to each individual. If there's one of those things that, like, if you wanted to have the complete picture, and this is saying like somebody who's never had an event, if you already had a heart attack stent, you're already high risk. You still maybe do 2 of these, but you're not going to do the third. So, let's say the protypical, I saw a guy today, executive, 68 years old, had no history. I recommend 2 of the 3 tests. I recommend the calcium score test and the CIMT to give us the vascular age. In the future, I'll probably recommend that he do an EndoPat if he has anything abnormal with those first 2 tests. But if really, I don't like to say if money was no object, because money's always an object, and it's always, what do you want the biggest bang for the buck? Go for the calcium score test. But if money was truly no object, you would do all 3 of the tests. You would do 2 of the tests that would look at, what's going on with your arteries in the whole time you've ever been on Earth, and then the EndoPat tells you what's going on right now with your arteries. Are they healthy? If they're healthy, then all that damage was there and it's not going to progress. But if your EndoPat's still abnormal, you're very likely to keep progressing unless you change something up. So, if I had my druthers, I would do all 3 on everybody.
Okay. Yeah.
What's the usual cost for that blood panel?
It completely depends. You start adding on genetic markers and everything else, it can be over $2,000 sometimes if you were paying 100% out of pocket. But most of these labs aren't set up that way. They'll have a max cap that they'll actually pay out of pocket. But everything varies depending on what your insurance is. If you have a high deductible health plan, you're probably on the hook for the first couple $1,000s of anything that you get done before insurance kicks in. So that's why it's hard to kind of claim, oh, this test is always, for labs especially, this test is going to be exactly this price.
Being used for blood panel?
For most people, it's usually covered a certain percentage. And, yeah.
You mentioned something about, you mentioned something about that, like LPA or something?
LP little a.
Is that something that a regular?
That can be done yes, I mean, it's about a $20 test, and they can run it at LabCorp request. It doesn't have to go to a specialty lab. So just ask for LP little a or lipoprotein A. And everybody should be honestly checked once for it. If it's low, you don't have a problem with it. But if it's high, again, there's not necessarily great treatment for it at this time. There's a couple supplements sometimes we try in people, and you'll see it go down a little bit. But the data isn't there yet that if we know if you lower it, you're lowering risk. So you focus on everything else first. Was there a question here?
Quest has more recently, in the last couple of years, they have a cardiac panel.
Correct.
You're probably
Mhm.
familiar with it. What is that related to? Do you do something different? That's something they do if your doctor orders it, and they market it as showing additional markers, risk factors for cardiac stuff.
Correct. So I use a company that got acquired by Quest, so they use very similar technologies, but they're mostly checking the lipid particles that carry the cholesterol, and then they also do a lot of the inflammatory markers, high sensitivity CRP. There's a couple other ones, myeloperoxidase.
So your tests are different?
They're very similar. They're cousins essentially. Quest owns the company that I usually order through. I usually use Cleveland Heart Labs because I've had good experience with them, and they have a lot of data on their inflammation panels. And they do a couple things that other labs aren't doing just yet.
When you talk about fish, it's much health, it's good, healthy, but what about fish that's farm raised opposed to?
It's a good question. Good question.
Yeah.
Quality is always going to matter, but and I usually get the question too, like what about the heavy metals of fish? It's honestly, the DHA is so critically important for running the machinery in your system that it almost doesn't matter what the fish was as long as you're getting the DHA. I don't really say that to go out there and eat horrible quality fish, but the DHA is that critically important. So if farm fish is all you can find or afford, just look to try to see where the farm fish came from. If it's in China by a coal factory, you might have a problem. If it's somewhere in the States and you know kind of what they did, you're probably better off with it then.
If it says wild caught, that's a
Wild caught would be preferred if you know it's truly wild caught. Sometimes that might be a marketing gimmick for some people, but if you know it's truly wild caught, it just means that, honestly, it depends exactly what they mean when it's wild caught. It's because it depends where they're wild caught at. Yeah.
Like wild Alaskan.
Right.
Or Norwegian.
Right. I mean, that's the thing is that the colder the water, the bigger the fish. So that's why you're going to see most of them from Alaska and the Arctic.
Would you please clarify your statement on the frying of the fish?
When you
Deep
heat something,
fry.
if you heat something too high, you unravel proteins and you basically burn the fat. So anybody who's ever thrown oil in a frying pan, you see it smoke up. Well, you've now changed it from the way it was initially made into something different. And then you put something that's damaged into your system. Now your body has to deal with that damaged oil or the denatured protein. The body doesn't know what to do with that abnormal protein as much.
So what would you recommend? I mean, usually I like to sear the salmon on a, skillet that doesn't have any oil, whatever, just kind of crisp it up, the skin at the bottom.
I mean, are you eating the skin included, or?
Yes.
Okay. I don't have you'd be about the first person who's ever asked me that particular question, but I don't know exactly. I mean, it would be, excuse me.
I mean, I'd rather grill it outside, but during the winter it's kind of tough,
Sure.
On a cedar plank,
Sure.
that's my favorite way of grilling
Yeah, I
myself.
mean, it's, if it turns black, you've destroyed the thing that your body doesn't want to put into it. Essentially, you get these advanced glycation end products. So, it basically causes candy appling of certain cells when you eat this junk. So, if you could, just slice that part off and eat the actual flesh then.
Or bacon.
Or bake it, yes.
See, this is from my wife because she likes it crisp and stuff. And I used to bake it and she says, it's not crispy enough.
Yeah.
You can bake it home.
I know, I love to
I
bake
mean, I
it.
make salmon for an hour. and it's
I,
really
there, I'm just gonna ask you, because you seem to know so much. Is there truly, could there possibly be any connection, because we know any people that have had, men that have had this, they have a heart issue, unhealthy heart attack, stents, whatever, statins, prostate, prostate numbers go up.
Prostate numbers go up.
Do you know anything of that? I mean, it's just coincidental that we have people that,
Yeah, I have not seen that in the data that statins, have a side effect of, because PSA is a, substance secreted from the prostate. It's like the sewer pipes of the prostate. I have not been aware of any data that it blocks those sewer pipes to raise the PSA, because PSA is not a sensitive enough marker to say that, there's cancer. It just says that, the prostate's releasing this substance. So those people would need to have like a cardiac MRI or ultrasound to know how big the prostate was, if it's actually a problem or not. But I've not seen that clinically, no.
Dr. Twyman, what's the best way for people to connect with you
So-
in the future?
So either, if you go to Apollo Cardiology or you look at, just go on Google and type, Dr. Twyman or Michael Twyman, MD, you'll find my websites, or you can follow me on social media if you're on social media. But I'm on Facebook, Instagram, Twitter, LinkedIn, TikTok, if you know what TikTok is. That's the cool new one that the kids are using. I'm on all the social media platforms, so I'll connect with people wherever they would like to see me.
So we can dismiss, you guys can hang around, I'm sure
Good.
Dr. Twyman will be happy to just kind of mingle and answer questions, but feel free to stand up, you've been sitting a long time. If anybody